changing the timing and the pace of labor. That could be withholding food and beverage, forced positions, sweeping the membranes, and induction. So this is a big topic in the class. A few years ago, people would go to the hospital here and they would eat in labor. And sometimes they'd have someone, a nurse, say, don't eat, you're not allowed to eat in labor. And sometimes they'd have someone who's like, oh, would you like me to bring you a spoon so you can eat that easier? Like, it was super inconsistent. So a parent group asked, we used to have a parent advisory panel for the hospital. I don't think they still have that anymore. That kind of got squished with COVID. But so they asked, they're like, okay, we want a policy here. And everyone fully expected the policy would match what's happening in most of Canada now, where they say, eat if you're hungry, right? No, our policy came back and said nobody eats when they're in active labor. And so that's the policy. Remember, policy governs the staff. So they have to tell you, no, you can't eat in labor. But remember, you have all the choices in the world and you can choose to eat or not. If you're laboring at home and you still feel like chewing food, you're not in active labor. It is too early to go in, likely. Like I would say 99.99% chance that you're not in active labor, and it's probably too early to go to the hospital if you're just going based on where you're at in labor alone. Okay. There are like, the reason this is recommended is if you had to go to the OR and if you needed a general anesthetic, then there's a very slim chance. It's 0.66 per million. Okay, that's like 0.00066% chance of someone throwing up into their breathing tube, because most women will be awake during a cesarean, for one thing, and they do provide anti-nausea medication on the way in. So this whole policy is probably leading to more cesareans. There is research showing, surprise, surprise, when we deprive laboring women of nutrition, nutrients, then they're more likely to go to the OR. Not really a surprise. So if you feel like eating, you have options. You can just ask for the waiver and eat. I don't think it's a great idea to sneak food, because if you do need to go to the OR, the staff needs to know, when did you last eat? And they're going to ask you that anyway. It leads to women being, like the laboring women, being hangry, exhausted, and low blood sugar for mom and baby. And that's not good. So, and it increases the rate of cesareans. So you can just say, I will eat. A lot of people, I see a lot of birth plans that say, I will eat if desired in labor. Please provide the waiver. And what would happen then is the staff would tell you all the reasons you shouldn't eat, what the concern is, and then you sign the paper and no one bugs you about that anymore. This mostly comes up like if someone's being induced. Again, prevention. If you know you're going in for an induction, eat like a piggy before you go in. Seriously, unless you've been told not to eat. But usually I even see the staff telling people, like, make sure you eat. Go get a big lunch before you come back for your induction. Okay. There's an article in your class resources, labor aid. It's an article on my website that tells you how to, like, some things you can eat, some nice homemade nutritive electrolyte drinks as well, if you don't want to do Gatorade or whatever. Things that count as clear fluids in the hospital: water, fruit juice, some fruit juice, like apple juice for sure. They have some flavored drinks, like if you're drinking Gatorade, if they can see through it, it counts. Jello, popsicles, broth. Some people really like a good broth. And for some reason, tea or coffee, which isn't see-through at all. I don't know. I've never seen anyone in labor drinking coffee, but for some reason that's on the list. So those are things you can have. And if a lot of women don't feel hungry in labor, and sometimes us birth workers are like encouraging them to get something into them. So that's where having a nice electrolyte drink or tea with honey, Jello, like sometimes, or even just fruit juice, like just something to get a little bit of sugar in the tank. Okay, then we have forced positions. These really change the pace of labor. As you know, this is my least favorite birth position. This includes being confined to the bed. Now, the note is forced. Every now and then I see someone who likes a position that I imagine isn't great, but whatever, they're progressing, they feel good, that's their choice. Awesome. Doesn't matter what anyone else thinks. So being told that the most common thing here is being told to lay on your back and have your baby. And mostly that's done for staff habits. Sometimes you're asked to be like stay in the bed because of safety issues, like with an epidural. And sometimes there might be some kind of a health issue that will prevent someone from being safe to get up. Giving birth on your back is easier for the healthcare providers, really. And if your legs are numb, it's safer to stay in the bed, but that doesn't mean you need to give birth on your back. Remember the video from last week? You can take all kinds of different positions and still be on the bed. And sometimes you need help to get into those positions, but you can. So the risks of being forced and like, let's say to give birth on your back, slower progress, more tearing, increased pain, feeling of like disempowerment and less choice. So just, do what you want, unless there's a clear medical reason. If someone has to use a vacuum or something to help your baby out, then that position is on your back. That's how your healthcare providers are trained to do that. And when things like that happen, we want to do what is gonna work best, especially for the staff who are trained. At that point, you have fewer choices. Remember, sometimes you start labor with all the choices, and then as things go on, you just have fewer and fewer choices. Sometimes. Other times, people keep all their choices all the way through. Here are ways of being on the bed. So this person is meeting the requirement to stay in bed. Let's say if they had an epidural, and there are all kinds of different things you can do. And there's like 20 more than this. But these are all, they can be helped into this position, these positions. Here's someone who's having a very medical birth, all these IVs and everything, but she's still upright. She still has her partner close, and maybe this is the only choice she has left. Do you want to be on your back or do you want to be upright? But she still has a little bit of choice here. And that's a squat bar, by the way. We have squat bars in our hospital that you can use. It's the easiest way to not give birth on your back is to just not get on your back. Like once someone, especially when you've been in labor for some hours and you're feeling heavy and tired, and then you get on your back and it's just really hard to be like, I want to move because you feel like you can't move anymore. This is where support makes a big difference. Like, hey, let's help you into different positions. Everyone who works at our hospital knows how to catch babies in all kinds of different positions. And every year I do this work, I see this changing in a positive way, that there's so like less and less arguments about this. There are still some doctors who will say, oh, right at the very end, I want you to get on your back because then I can help your perineum and I can support you better. I mean, I guess that's a choice you can make or not. By then, the baby's probably so close to being born anyway. But if it doesn't feel good, especially if it hurts to be on your back, then you just say no. Easier said than done, but that is an option. Okay, sweeps and internal checks toward the end of pregnancy. I picked this picture because this is the face most people make when they're having a deep cervical check or a membrane sweep. It's uncomfortable. And the good doctors will be honest and tell you, midwives do this too, not just doctors, they'll tell you this hurts. So what this means is during the end of your pregnancy, toward the end of your pregnancy, like the last couple of weeks, most doctors and midwives now say you have to get a sweep. While doctors say you have to get a sweep, midwives say I'm going to offer you a sweep. It is a choice, okay? It's optional. The SOGC guidelines say it doesn't change gestation, but the theory is, on the other hand, that it brings on labor sooner and avoids induction. So I don't know. It might work. If your only option is that you're going to be induced in the morning, maybe it's worth a try. But the risks are, so that's the benefit, maybe it'll work. The risks are it's uncomfortable to downright painful. And the good obstetricians will say it's really uncomfortable. I heard one of my clients told me her OB told her 40% of her clients who get it tell her to stop because it hurts. Some people don't mind. They're like, it's for a good cause. Let's do it anyway. The risk is that your waters release. Premature rupture membranes, meaning the water's released before you're in labor. Now you're on the clock. Now you're on the infection clock. It can lead to spotting and painful, ineffective sensations, increased risk of the baby getting GBS if you're GBS positive. So one of your considerations with this might be, am I GBS positive or negative? Because if you're positive and your water's released and you're not in labor, you just signed up for medical induction. It's like whatever, obviously with everything, it's what you choose. You can decline the routine cervical checks. And if it feels weird to say, no, I'm not getting this, you can just say not today or leave your pants on, like I said. If you want your cervix checked, or there's a good reason to do so, but you don't want the sweep, you need to be very clear on that. You need to tell your doctor or your midwife that you can check my cervix, but I do not consent to a sweep. Okay, because a lot of them will just do it while they're in there anyway. The thing is, these cervical checks aren't predictive. I've seen women walk around for 4 weeks at 4 centimeters dilated. These are people who've given birth before, and they feel like a time bomb because they were told now, oh, your cervix is 4 centimeters dilated. You're going to have your baby any second. I've recently worked with someone who walked around like that for 3 weeks before she had her baby. And other people are told, oh, your cervix is tight and closed. We're going to have to induce you. And then they end up going into labor shortly after that. So it's not predictive. So you get to choose. That's the bottom line here. Like everything else, you get to choose if you want this or not. You might say no early on, and then at 40 or 41 weeks, you might decide, well, let's try it. I don't want to be induced, and I feel like induction would be the best way to go otherwise. So you have choices. Induction. Induction means starting labor, basically. And there are several ways to do this, breaking the water. I think everyone in here is having their first baby, so nobody's going to ask you that. Balloon catheter. There are some medications, 3 groups of medications, Cervidil, Pitocin, and Cytotec. Okay, so a little background on induction. So forever, since humans have been having baby, people have been trying to figure out how to get labor to come, whether there's a medical reason or they're just tired of being pregnant. So that's one thing. And there are certainly times where it's safer to not be pregnant anymore. And when that happens, then it's a good thing we live in the time that we do, because the induction methods now are way better than what they used to do way back in the old days. So anytime it's not safe or healthy for the mother or the baby to be pregnant anymore, then induction, it's like, thank goodness it's an option. Benefits, like for sure, there might be 2 options, either have a cesarean or do induction, and you can ask about that. Sometimes it's done by preference of the pregnant woman, but not very often. A lot of people are blaming the increase in cesareans for that, and they're like, oh, well, women are asking. No, not very many women ask for that, okay? No, that's just so not true. Sometimes inductions are done for myths such as large baby, and the guidelines say you shouldn't do induction for large babies because ultrasound is notoriously inaccurate. The most common reason for induction is based on dates. And if you want to go down the rabbit hole and learn more about that, there's links in your class resources. Evidence-based birth has some good information about induction for dates alone. Okay. A lot of people worry about doctors inducing them because they want to go on holiday or something like that. That doesn't happen here, ever. Like, if your doctor has to go on holiday, they will trust that one of their wonderful colleagues is going to look after you instead. So you don't have to worry about that. You don't have to ask in your birth plan, like, don't induce me for your holiday or something like that. That doesn't happen here. Okay. So, the risks of induction, it's usually a harder, more painful way to labor. It does often lead, almost always lead to more interventions with that cascade of interventions. It turns birth into quite a medical experience, and it can up to double the rate of cesareans, depending on why and what method of induction is being used. I'll mention there are some natural alternatives. Acupuncture, if anyone wants the name of people who do, there are a couple women in town who are acupuncturists that specialize in prenatal and induction. They're awesome. So you can ask about that. You could do something like castor oil. Doesn't work great in first timers, but it is an option, sometimes worth trying. You could wait, you could just say no. Of course, that's an option as well. You could say no. And I've seen some doctors lecture people and they say no. Other doctors say, okay, no problem. I'd like to see you twice a week and just do a little more monitoring on the baby. Great, that's an option as well. I mean, it might not feel like an option if you live 3 hours out of town, but if you live locally and you're just driving in to get a little more monitoring, maybe that's worth it to you. You get to decide. You don't have to be induced. This is probably the number one thing I hear in the have to category. Oh, my doctor said I have to be induced. You don't have to be induced. You're not a prisoner. It's your body. You can have a good conversation with your healthcare provider, and then you can choose to be induced. I like that narrative a whole lot better because then you feel like there's choice, or you can choose to not be induced. If there is a medical reason, then another option is to just embrace it and know that, okay, this is how we're doing it, and that's okay, and we're going to make the best of it that we can. I've been to lots of inductions that were lovely and smooth and easy. I've been to more that were difficult. So, okay, if you're on the list, this is if it's for dates, especially if it's for dates, your doctor might tell you you're on the induction list for Tuesday. Okay, Tuesday, great. And then Tuesday comes and you don't get a call. And you've been told you have to have your baby because it's a number on a calendar. And after this number, it's no longer safe to be pregnant. So then you feel like a time bomb. And Tuesday comes and nobody calls you. Or if you call the unit, they say, well, we don't have room for you. We'll call you tomorrow. And then tomorrow comes. Maybe you get in, maybe not. Maybe it's an extra day. I want to reassure you that if you're on the list, everyone's put into an order. And the people who really have a medical reason, who are sick, who really need to have the baby, they will get called in. If you're there for dates, then you are the person who's going to get bumped. And if the staff has any worries about you, they're going to ask you to come in for extra monitoring and then induce you or send you home. So if you're still on the list and not being induced, it's because your healthcare providers are pretty sure you're good. Okay. So just want to make sure you all know that about the list. Now, induction is a two-step process. And this is really important when you're thinking about induction. The first part of induction, the first step is getting the cervix soft. We call it ripe. A ripe cervix means it's soft, it's getting thin, it's starting to dilate. Remember the lifesaver? So the lifesaver is getting a little thinner. That's the first step. That's step one for induction. And there are different ways to induce. So the first thing is to get a cervical check. And if you find out, oh, your cervix is not yet ripe, then you do step one induction. If you find out your cervix is actually starting to change, this is more likely in someone who's given birth, but it could happen with a first timer, then you would go to step two induction. So you don't always have to do step one to do step two. It depends. If your cervix is ripe, you go to step two. And that's with medications to keep things happening, to bring on the contractions, okay? So if you have step 1, your cervix needs to be ripened first. Once that's complete, your body might just take over and you just keep on going and have a relatively normal birth, or you might then need to do step 2. Now your cervix got ripe through induction and you still need some help to get going. So then you do step 2 of induction. Okay. So you're going to start at step 1 or step 2. And not everybody has step 1 and 2. I hope that makes sense. So I'm going to talk about first the ways to ripen the cervix, and then we'll take a break. Okay, so one of the ways to ripen the cervix is, remember the balloon? We talked about the Foley. This goes into the cervix and gets blown up, and it's called a manual ripening. And it's inserted at the hospital, and then you get monitored. And for a little while, make sure mom and baby are tolerating it. And then you go home and you just wait. And if it falls out, it's working. If it falls out, that means your cervix has opened up a little ways. So this would only be done if your cervix was not yet ripe. This is for ripening. Benefits are there's no drugs. You can just go home and wait. And hopefully that'll be enough to get labor going. And maybe you don't need any further intervention. That would be nice. It can be quite uncomfortable. And hey, you're all having summer babies, I think. Last summer, one of my clients was like, why didn't you tell me I'd have a balloon or a rubber tube hanging out of my shorts? So don't wear short shorts, I guess. I never thought about that actually. So she had the balloon and this little tube hanging out. So there's a hot tip for summer pregnancies. So, and the alternatives are the same as with all the induction. Like, and by the way, I'm not telling you alternatives is always ask for more information, say yes or no. That's always an option, right? And that's included with induction as well. And your other alternatives are to do the natural. This goes with all of induction, or wait and get the monitoring, or embrace it if you're choosing it. Okay. So if that works, then if you're not in labor yet, then you might go on to step 2 induction. And if you are in labor, maybe your body's just going to keep right on going. That would be nice. Okay, the next one is Cervidil. This is only used. Oh, by the way, the balloon will not be used if your waters have released. And the Cervidil also will not be used if your waters are released. So if your waters are intact, Cervidil is a medication that can soften the cervix, ripen the cervix, this step 1 of induction. And it's delivered on like a little flattened string, and it just goes and sits up against the cervix. Cervidil is a prostaglandin. That's the name of the medication, the group of medication. And this would only be done if your cervix wasn't ripe. It gets inserted at the hospital, then you get monitored and go home, and you'll be given instructions if your contractions do this or that, come in, or if nothing's happening after 12 or 24 hours, depending what they use and what your needs are, they might ask you to come back and get another dose. So if you've heard of someone who said, I was induced for 36 hours, it's probably that they just had to keep going back and forth to get a new Cervidil put in. I mean, it's as far as induction goes, it's not as invasive, or not very invasive. There's no IVs and things. And then it's easy to take out if the uterus stimulates too much. It can lead to very strong contractions that are painful, and they may or may not be productive. So some people end up going to get morphine or something just so they can kind of cope. So this is a step 1. If your waters are released, or if your cervix is already ripe, you will not be offered Cervidil. Now this medication, Cytotec, this is step 1 and step 2. So if your waters have released and you need your cervix ripened, then, oh, here we go. It's pills. You drink it. They give you water and you drink it. If your cervix is not ripe and your waters have released, you will be offered Cytotec. Okay. There have been a lot of problems in the States with Cytotec. I assume we're using it differently in Canada. We've just started using it recently, and you have to stay in the hospital with this one. So if your waters are released and you're agreeing to induction, be ready to stay at the hospital, okay? This can cause some pretty monster contractions that can be harmful, and therefore you have to stay in the hospital where there's the antidote nearby. The staff can act and give you the medication to stop the effects of this if needed, okay? So, I mean, if you need to be induced and your waters are released and your cervix is not yet ripe, then this is probably a good option. If you go to step 2 induction and your cervix is not yet ripe, that's where we see double the rate of cesareans, because the stage 2 induction doesn't work very well if your cervix isn't ripe. Sometimes it's worth a try anyway, but that's just what the math says. So Cytotec can be used for stage 2 induction or for stage 1. If you started with Cytotec and your cervix got ripe and you still needed some more induction, they would just keep going with this medication. You take it orally. There's a whole protocol for how often. Pitocin, oxytocin, syntocinon. These are medications that are meant to cause uterus contractions. Cytotec does that too. These are not meant to ripen the cervix. That's not how they work. So if you go to be induced and it's found that your cervix is already ripe, or if there's just like your health is tanking and they have to try something anyway, you might go straight to Pitocin, oxytocin, syntocinon. They're all synthetic. They are not the same as our own hormones. I've heard a lot of people being told, don't worry, oxytocin, your body makes it. It's the same. It's not the same. The big difference is the oxytocin, the labor hormones we make, leave our brain, go through our body. They get our whole body in labor. If you remember the video from week 1, the woman who looked like she was in labor land, that's the effects of natural hormones of labor. These don't do that. But if we need to get a baby out, they can be very effective at squeezing the uterus. They can also be used postpartum to stop bleeding. They can be used when you're already in labor, these medications. So if you're already in labor and you need your labor sped up, this is the medication you're going to get. No one's going to say, oh, do you want a balloon catheter so we can speed up your labor? No, that doesn't happen. Okay. It would be and these are delivered with an IV, always with an IV and always with a monitor, a continuous monitor. If you're getting oxytocin, Pitocin, or PIT, Synto, or syntocinon, then you need to use a continuous monitor. I would say if you refuse to use the monitor, they would turn off the IV medication, because it's really important to know what is going on with the mom and baby. Some babies don't tolerate this at all. People are more likely to have epidurals if they have this kind of induction as well. So it can be more uncomfortable. It definitely, birth is highly medical. Now you've got an IV and monitoring and more likely pain medication. But remember, the benefit is sometimes we have to get babies out. And this is one way to do it. And some people tolerate this really well, especially if they've been having acupuncture first or their cervix was already ripe. Then in that case, if their cervix was already ripe, there's not much difference in the rates of cesareans, because that's how this is meant to work. So it's like your body is already doing what it needs to be doing in some ways, and it's just being picked up or started. You don't have to ask the staff to start low, because they always do. There's a whole protocol. They start low, they make sure everyone's safe, and then they turn it up every half hour until you're in a regular contraction pattern, and then they don't turn it up anymore. So you don't have to ask them to stop turning it up. You don't have to ask them to start low. There's a whole protocol. They are very good and respectful and safe in how they use this. Okay. And no one's going to sneak up on you. I see a lot of birth plans that say, do not induce me, do not use any medication to speed up labor. You don't have to ask for that because no one sneaks up on you and does this. You'll have a conversation ahead of time. You'll sign a consent form. If you're already in labor, they'll ask you before they use this medication. They'll wait to get your consent. And here's this is what induction often looks like. So she's got the IV running here. She's got her monitor on, but she's still upright, wearing some of her own clothes, still even smiling, has her partner nearby, again, using the squat bar in a different way. With consent and induction, you are consenting to be induced. You're not going to be asked to choose which way to be induced. So you don't have to remember all this stuff. Just ask your questions. Your doctor will look at what's going on. And if you're with a midwife, they'll have an OB check you out. They'll transfer you or at least consult. And they'll look at the whole picture and they'll make a recommendation for how you're induced. You don't have to know about, well, do we want the balloon or do we want the cytotech? Like the options, they have a whole grid. The options will be really clear for you, okay? So all you're agreeing to is to be induced or not to be induced. And then, of course, ask as many questions as you need to ask to feel comfortable with the care you're getting so you understand it. But, they study for many years to know these things. So they'll help you go through the whole thing.